pathophysiology of gastric diseases or condition. Yeah? I think in our last lecture, we cover on stomachs, for stomachs diseases, and now we're going to look into the pathophysiology. So this content of lecture 4, we look at gastric diseases, condition and lesion, and then clinical sign. One of the clinical sign, although not necessarily be there, is the way you have vomiting. In contrast of vomiting, we have vomiting, and the other part we have diarrhea, isn't it? They will be on GIT on our lecture 5. Then important thing with regard of stomach is gastric erosion and ulceration. Ruminal acidosis, remember about gain overload. And then we discussed a bit also on bloat or tympany. And last, finally, is parasitic gastritis. You remember that abomasum, one of the most important one is homuncosis, isn't it? So this is a very nice session or histological section of stomach mucosa. I mentioned that this is how nice it look like. They are more of granular structure. They consist of gastric pit, isthmus, and more importantly, two important cell have is a mucus secreting cell. We have surface mucus secreting cell, as well as those neck of mucus secreting cell, where the role is to produce mucus. Another one is what I call it parietal cell, which is important on the production of HCl and maintain the acidity of the stomachs. But problem will arise when there is imbalance between the production of mucus secreting cell and the acid, and that lead to formation of more commonly like erosion, and perhaps in severe cases might have ulceration. So gastric diseases, condition and lesion. I think you can look at gastric diseases or condition and lesion. I think the lesion, one of the important one is ulceration. It's a lesion. This is tissue response to injury. Inflammation of the stomach is gastritis. There will be also an obstruction. I think, but more importantly, when you obstruction, whether as a result of primary or secondary in cases of blood, or could be also of displacement, or in case of torsion, will lead to over dilatation or over distension of the stomachs. Occasionally also neoplasia can be a problem or condition of gastric diseases. As a result of that, when we have a lesion that lead functional abnormalities, that's why we will lead to gastric dysfunction. And clinically, what you expect to see, a patient with gastric disturbances or condition might show of abnormal pain, abnormal pain. Then they might have also abdominal distension, maybe vomiting, anorexia, loss of appetite, then hemoptysis, they got blood there, and as well as anemia, particularly when it's something to do with ulceration. So clinically, we can observe those, but sometimes also there will be what I call abnormal, sound of the GIT. And clinically, we can do auscultation and look for different sound or content of GIT. For example, you might be able to differentiate between the gas sound in cases of what I call it secondary blood, or maybe more foamy sound in cases of primary blood. So your auscultation by your stethoscope in the abdominal cavity, listening the sound changes in the stomach is very important to understand, particularly on the abnormalities of gastric dysfunction, in addition to looking at what you can observe, the clinical sign. Vomiting you can observe. Abdominal pain probably you can observe also from the patient, but yet sounding or auscultation might give you some indication of these gastric abnormalities. The clinical signs associated with gastric pain, usually they are associated with release of chemical mediator or inflammatory cell or inflammation, particularly involved with ulceration. So pain a lot involved with ulceration and occurs shortly after eating or increase in the secretion of gastric acid. So you remember if during a fasting month, people might not able to do fasting partly because of they have gastric disturbances as a result of this disturbances of balance between hydrochloric acid production, HCl production, as well as mucus secreting cells. Meaning that if you don't eat, the tendency of excessive amount of hydrochloric acid in GIT, and that might lead to condition or lesion of erosion and ulceration. So in patient with gastric disturbances, animal also might have loss of weight, partly because of impair of digestion, reduction of food intake, and exudation and loss of plasma protein. So they might have lost weight. This loss weight also sometimes you remember carefully. This is very important, particularly in producing animals. Yeah? When we don't want, for example, broilers of our cattle in feedlot have impaired digestion and lost weight, because this is not economics. Yeah? We put the feed, we like to see more of feed conversion ratio is the most effective one, but not impair of digestion. But sometimes people do it for this impaired digestion, quite good in terms of to keep the body slim. So you can keep your body slim if you have impaired digestion. And even sometimes the food intakes as well as is controlled partly by the size of the stomach. The bigger the stomach, there's tendency that the animal might take more food than those are small one. And sometimes in human being, they modified by doing what I call intervention and keep the stomach small so that they will take less feed and keep the body slim. I think this is not a good practice. There's also a bleeding from the ulcer. That's why sometimes if those patients with gastric ulcer, we might expect to see some occasionally they vomiting of blood, isn't it? And with the loss of blood, animal also might have anemia. So these are some of the common clinical signs you expect to see in animal with gastric disturbances or dysfunction. The animal pain, loss of weight, hematiasis, as well as anemia. One of the clinical signs also involved is vomiting. Okay, I think we experience this vomiting. Although usually this vomiting is a result of irritation of the gastric mucosa with stimulate of vomiting. They're involved with stimulation of medullary vomiting center in central nervous system. They are common in dogs, cat, and human. If profuse and persistent serious metabolic consequences, such as animal might lose a lot of water, they become dehydration or hypovolemia, they become loss of hydrogen ion, leading to metabolic alkalosis, loss of chloride, hypochloremia, and loss of potassium, hypokalemia. So vomiting also is quite common, but severe vomiting, of course, could lead to death to the animals. Probably due to the loss of water, dehydration, as well as loss of those, what I call it, ion, which is very important, might lead to metabolic acidosis or even hypokalemia or hypokalemia. So it looks simple, but vomition could lead to death to the animals. But please note that vomiting might not be related to a primary gastric disease alone. You can see also in cases of severe pain, excitement, fear, irritation of peritoneal and abdominal organs, toxin, drugs, and abnormal motion, mean that motion sickness. Okay, so I think motion sickness something that is quite what you call it, quite familiar you all. So there's a possibility that might lead to also vomition, not necessarily as a result of primarily as a gastric diseases, but it's one of the important indicator of clinical sign of gastric anomalies. Let me look in terms of the consequences of gastric erosion and ulceration. I think as we discussed earlier, there's quite a number of agents that can cause gastric erosion and ulceration, such as an infection, or maybe caustic compound, which lead to ischemia, and more importantly, which is more common, is autodigestion as a result of excessive production of hyaluronic acid. And as a result of that, there will be a death and desquamation of mucosa with necrosis, first leading to formation of erosion, but if deeper enough, they lead to formation of ulcer. Remember that ulcer will involve with the basement membrane, mucosa leading to in touch closely with also the blood vessel. So this leads to bleeding. Form is perforation, and usually might involve when the perforation with peritonitis. Because what happens is that when this perforation, the gastric content will enter the abdominal cavity. And as I mentioned earlier, GIT have direct communication with the environment. There's quite a number of pathogenic and non-pathogenic bacteria that is present in the lumen of the GIT. And as a result of those perforation, they will lead to peritonitis. If severe peritonitis, for example, they will lead to death. I think we discussed earlier, when animals have peritonitis, as a result of usually associated with secondary bacterial infection, what I call it toxemia, and dilatation of the blood vessel will lead to reduce venous return and reduce cardiac output. And when there's reduce of cardiac output, there will be reduce of oxygen and nutrient supply to the vital organ, particularly the central nervous system, and low oxygen leading to ischemic necrosis of vital organ, particularly the brain, and that will lead to what you call it dysfunction or failure of the central nervous system. We include also the central secretory disturbances and respiratory center and death to the animals. So peritonitis, perforation of the GIT could lead to death to the animals. Any questions so far? Class, any question? Class, any question? No, yeah. I think what I this pathophysiology partly also have touched during the lectures in lecture 3, yeah? But now you just try to emphasize, and we put it separately because it is important to us to understand with regard of the relationship between the agent, lesion, as well as the clinical sign. So that is important. And in the gastric mucosa, they have actually gastric mucosa barrier. I think this also I have touched previously. To prevent autodigestion, we have gastric surface cell, which is actually secreting mucous cell, and they are also what we call it hydrochloric acid produced by parietal cell. So this should be balanced. When they are balanced, so this mucous very, very important, and you don't expect to see any of this autodigestion. So usually they consist of thick, viscous, alkaline mucus on the surface of the mucosa. This mucus is produced by surface epithelial cell and submucosa glandular cell. And this cell, like later on in the intestine, they have heavy turnover rate of mucosal cell, and it may take replacement within about 3 days. So they are also continually replaced of the epithelial lining of the gastric mucosa. Okay. Similarly, also in the cephalosporin epithelium, they are also continually replaced. And later on, when you go to intestine, the epithelial lining, also the intestine, are continually replaced. This is a part of the barrier that they have. And in response to injury, they can lead to heal by epithelialization, or if it's severe enough, the healing will involve with granulation or formation of fibrous tissue. So when there's a mild injury of the mucosa, then in cases of erosion, they will increase mucus secretion, and those damage of the cell as a result of erosion will be healed by desquamation. And repair usually take quite repeat within 48 hours. However, if the severe injury is become severe or serious, that lead to ulceration and most likely death to the animals if it's severe enough. So when this erosion will lead to severe injury leading to ulceration, ulceration will hit the blood vessel and there will be a bleeding. There are two possibilities. One, there might be a repair, and if the repair is complete, it may take several months. And the area will be replaced by fibrous tissue. By fibrous tissue. And animals also, when they have very severe ulceration and bleeding, even without the perforation, animal might have acute death. They may have acute death. But when they have a chronic ulceration, where the repair is not complete, I mentioned earlier, they will be leading to perforation and peritonitis, severe bleeding, and this peritonitis and severe bleeding leads to death to the animal. So ulceration is important, and ulceration also can be severe and lead to death if you compare with erosion, which is mild, and healing by desquamation. But in this case, if repair involved, they will involve with fibrous tissue formation. But most worse is that if you involve with perforation, severe bleeding, and peritonitis will lead to death to the patient. A condition called ruminant acidosis, okay, or they call also dilactic acidosis. And I think this involved with ruminants. In the rumen, I think we discussed previously on grain overload as a result of excessive or immediate change of diet from grass into concentrate. They might cause a grain engorgement or engorgement toxemia. So this is ruminal acidosis. And I think the most common people might thought it as a grain overload. And this is as a result of ingestion of highly fermentable carbohydrate, usually starch-rich grain, and the acuteness and severity of the severity increases with the quality. The more that they have, then they have more severe, and usually the incident is acute, partly because animal will have distended abdomen, bloat, and as we discussed earlier, bloat can kill the animals. The pathological gastric diseases, usually in normal rumen, they have gram-negative bacteria is more dominant, but many protozoa also present. So this is very important in terms of the ruminant metabolism or digestion, process of digestion of the bacteria, because if you remember in terms of the nutrition, in terms of digestion, they involve fermentation products. This is more important by process of fermentation because the digestive system of monogastric and ruminants are different. So the fermented product involved in the production of acetic acid, propionic acid, and butyric acid. And when this is excessive carbohydrate, in cases of ruminant acidosis or grain overload, there is elevation of bacteria, which is Streptococcus bovis, will lead to decrease in rumen pH. When this reduction in rumen pH, that will lead to what I call it increase in bacilli and excesses of lactate. And this excessive lactate will lead to osmotic diarrhea, as well as increase in ruminal Clostridia and coliform. This lead to chemical ruminatitis, absorption of histamine, of endotoxin. Animal might have endotoxic shock with excessive lactic acid. Similarly, they might have also metabolic acidosis. Actually, there will be another arrow here. When there is metabolic acidosis, that will lead to what I call it impairment of the circulation. Impairment of circulation as well as function of organ lead to reduced cardiac output. It's one more arrow here. Okay. And then there will be osmotic diarrhea, dehydration, diarrhea leading to hydration, hypovolemia and death. And cardiac output could be also another arrow here I missed there, could lead to reduced cardiac output. Of course, they will lead to death also. And one also they can lead to renal failure and leading to death. I think we are going to understand how reduced cardiac output lead to death. Again, is ischemic necrosis and vital organ failure. So these are consequences, what we call as a result of ruminant acidosis or grain overload. One of very specific condition and quite common we observe, particularly when involved with acute or immediate change of diet in ruminants, though sometimes also as a result of excessive intake of the concentrate. Some of the flow chart you can see there regarding the ruminant acidosis or grain overload. I mentioned earlier, it might occur as early as 2 to 4 hours. Increase in the bacilli, gram-positive cocci, Streptococcus bovis, lactic acid production, and there will be disruption of gram-negative bacteria and protozoa, leading to decrease in pH. So they preferably grows on Lactobacillus. So Lactobacillus is predominant, and plus there will be Clostridium and coliform within 24 hours. And both D and lactate are produced in equal amount, then peak of lactate in blood, and then leading to acidosis. I mentioned that in case we have metabolic acidosis, where acidosis could lead to interference on blood circulation, which is reduction in blood circulation, and as well as failure of other vital organs. There will be lactate in metabolism then, and usually animal might die within 1 to 3 days as a result of this grain overload. But usually the incident is quite acute, maybe just commonly seen within 24 hours. And you expect to see also the blood. Rumen acidosis or grain overload actually is a problem. There might be also a hypokalemia because malabsorption of calcium, laminitis because of release of histamine and toxin in the circulation, polioencephalomysia because induced vitamin deficiency, and animal might have also chemical ruminitis, where there will be fucobacterial infection and lead to abscess in the liver. So this is another complication. Gastric dilatation or bloat. Again, I'd like to emphasize here, I think we discussed indirectly, but without any flow chart during our earlier lectures. Bloat or tympany in ruminants usually is sudden gaseous distension of the stomach. And this distension can be a primary or secondary bloat, while the primary one as a result of excessive mucus production, foamy production, when the secondary one is as a result of excessive normal gas accumulation. with as a result of failure of this gas eructation. This primary and secondary. And as a result of that, they have abdominal distension. So when there's abdominal distension, there will be compression. Animal have difficulty in respiration because those of the standard abdomen will push the thoracic cavity, and then they will lead to restrictive respiratory failure. There will be hyperventilation, mean animal try to get more oxygen. So there will be, we call it rapid breathing, but it's in a shallow and rapid breathing, not death. So shallow and rapid breathing that lead to respiratory alkalosis. Remember, we have two: metabolic acidosis, and in this case, we have a respiratory alkalosis. And then they might lead to death to the animals. At the same time also, when there is abdominal distension, there is compression and occlusion of the blood vessel, the posterior vena cava, and that lead to low venous return and lead to hypovolemic shock. And as we quite familiar in our previous lecture, the clinical observed in cases of blood involved with abdominal distension, animal might show of abdominal discomfort, painting, pacing, little getting down and up and down, attempt to vomit, and prostration. Last one, we have parasitic gastritis. And one of the most important one is homunculus. Homunculosis. I mentioned earlier, we have very number of cases of homunculosis, particularly in goat and sheep. You can see here, this is the abomasum with the gastritis. You can see a lot of the worm in the lumen there. So in terms of homunculosis, if it's mild cases, usually there are no obvious clinical signs, except for animal have a poor growth. So in this case, we call it as not homunculosis, but hemangiasis. Hemangiasis means just an infestation of homunculus in the animal cavity, which cause any diseases. It can just interfere the growth to the animal. But when we have very severe infestation of the worm, because you understand that the worm actually is sucking the blood, and that lead to severe anemia, meaning that the worm will suck the blood, and animal will lose the blood. As a result of that, they have severe anemia. And this anemia, apart from the paleness of the mucous membranes, if the animal is still alive, there will be also serous atrophy of the bone marrow. How you see, normally when you suspect a case of homunculosis, you have to also open the bone marrow. And when you look at the long bone and look at the bone marrow, there will be a serous atrophy, meaning that those areas of the bone marrow been replaced by fat actually. It's more of a gelatinous appearance of the fat. And animals also have hypoproteinemia, loss of protein, again partly because of the sucking activities of the parasite. And as a result of this hypoproteinemia, they will have a pulmonary edema. You got pulmonary edema. Why the pulmonary edema? Because the, what you call it, pressure, the osmotic pressure in the blood is low as a result of low of albumin. There will be failure of the water to back into the circulation. So this is a mechanism of edema, where involved with controlled by the protein. We have osmotic pressure. Then we got tissue osmotic pressure, tissue pressure, and blood pressure. So when the reduction of the osmotic pressure, that will retention of fluid in the lung, and that lead to the pulmonary edema. And this reduction is osmotic pressure partly because of hyperproteinemia, particularly there's reduction of albumin. Similarly, also when the animal is in a poor condition, there will serous atrophy, meaning that you can see that gelatinous material, particularly in precardial as well as in subcutaneous fat tissue. So you see those of serous atrophy. So this is a typical lesion for homunculosis, particularly in severe cases. When you see the case, we expect to see anemia. Then when you open the animal, you might expect to see pulmonary edema plus serous atrophy of the fat tissue, including the bone marrow. Occasionally, what you call it, homunculus also present causing diarrhea. Please remember, this homunculus actually is present in the abomasum. Yeah, they are cause much problem. The what you call it, target organ is the abomasum. Another result we got is aspartagiasis that lead also loss of lung unit of protein, reduction of pepsinogens and hydrochloric acid. Animal might have osmotic diarrhea, bacterial fermentation, and anti-fitness. Okay. Oh, sorry. Any question? Before we take maybe 5-minute breaks, then we continue for the next one. The intestine one is much bit longer than other lectures. Class, any questions so far?
Prof, I have a question.
Yeah.
Like the reason why the bone marrow undergoes serious atrophy is it because the bone marrow tries to produce like red blood cells due to
Yes.
anemia? So
Yeah,
it
they will
forms.
excessive need of production of the red blood cell. Yeah, they will lead to the atrophy. Yes. I mean, those of the bone marrow being replaced by the fat because there are excessive use of the we want to increase more of the red blood cell. Yes, you are right. Okay. I think homunculus is a very good example to understand the pathophysiology as well as lesion when you refer to pathology because they are very good example. They have hypoproteinemia, they have serous atrophy. Some of the steroids are still the fat partly because utilization of the fat tissue as a source of energy because animal will be emaciated. Yeah. So they are very good examples. Any other question, please? If not, we take 5. We come back at 10:45. Now it's 10:39. So we come back at 10:45 to continue with lecture on the intestinal tracts. Okay. So see you at 10:45. Thank you. Okay, can we continue now? Class, can you continue now?
Yes.
Okay, thank you. We continue. We continue with international tracks. I think this international track is one of the most important topic of GIT for sure. In addition to the oral cavity as well as stomachs, because we can foresee that the role of the intestine is so significant. And of course, this organ also is a very long track when you compare with other, what I call it, other organs in the oral cavity or even in the stomachs. Oh, can you see the slide? You see the slide, eh?
Yes,
Okay,
Prof.
class? Yes, yeah, okay. So with regard to this, I think we cover on those of the 5 important topics. Again, I think still the most important one is the inflammation, yeah? Inflammatory reaction or the inflammation of the intestine, we call it as enteritis. Yeah. Then another part is very important also is the villus atrophy. They are very important. Although we only touch in this case only one slide, but they are so important. And of course, in terms of clinical sign, the diarrhea is so important. But not forgetting, of course, congenital anomalies is in other organ. They are more important in newborn animals. Obstruction, partly because of intestine is hollow organs. So that's very easy to get obstructed. Whether from the lumen can cause an obstruction from the lumen with the presence of foreign material, or a result of thickening of the intestinal wall. When the intestinal wall is thickened, they also lead to narrowing of the lumen. Not forgetting when there is some compression of the adjacent intestinal, or even when the intestinal might get twisted and so on, that will lead to obstruction. So these are very important topics of the intestine, although the most important of these 5, I mentioned earlier more on the inflammation, followed by villus atrophy and diarrhea. So when look at the intestinal tracts, the palatal lining or the lining of the iliac is villi, villus projection. So people always thought that the villus it look like finger-like projection. Like our finger, like our fingers, finger-like projection. But actually, when you look it under scanning electron microscopy, so this is electron microscopy, scanning electron microscopy of the villi. On the top of we look from the top of those villi mucosa. We can see that the projection also varies from the villi, only one, the villus projection, till until they look that they're more like a tongue appearance. Yeah? So there are different type of what I call it projection. Some is more look like villi, some like fingers, some is look like tongue, partly because when we have what I call it histological slide, depending on the type of sectioning we have. But in principle, you can see that in the intestine they have villi, and the appearance of villi varies from what I call it finger-like projection, like in this case, and some even look like a tongue projection. And the role of this villi is for increase the surface of the cell, to increase the space of the organ, to increase the rate or process of absorption. So this is under scanning electron microscopy. Then when you choose a very nice cross projection under histological examination, stained with hematocylin and eosin, you can see that there is a villus projection, very nice, with single columnar epithelial lining, some border lining, and they go to the tip. And of course, you can see those of the lamellopropia got a lot of impurity cell, as well as blood vessel and a lymphatic system. You see that. And we have a crypt of lubricum, where actually those cells that produce in the upper epithelial lining arise from this crypt of lubricum. So we have villus projection there, and we have a crypt of lubricum. And if you consider in this case, the epithelial lining of the intestinal tract, if you compare with the oral cavity, cephalic squamous epithelium, esophagus, squamous epithelium, stomach, glandular epithelium. Then we have the villus. Now they are become only a single epithelial lining or simple cuboidal and columnar epithelium. So only single, meaning they are very easy to get damaged. But fortunately also, they are also easy to get replaced from the, I could say, the factory or the cell at the crypt or lubricum. So the epithelial lining comprised of enterocyte. Enterocyte is a cell or a main of the villi, enterocyte. Then they have also what we call it a goblet cell. So when you look at the stomach just now, they have mucus secreting cell. They are also parietal cell, peptide cell. The mucus is so important and hydrochloric acid production is important. But you can see in this case, the mucus is still there also. And they are more of a goblet cell. And the main function of the villus is the enterocyte. We play an important role of absorption. Okay. So when you focus there, there's a crypt lubricum. You can see there is a mitotic figures where actually the immature cell will move from the crypt lubricum and towards the villus epithelial lining. And when you look under scanning electron microscopy, scanning, they cut the tissue, then you can see the scanning electron microscopy. What you can see here, we have an enterocyte. Enterocyte, it is the lining of the, what I call it, the villi, the nucleus. And to further increase the ability and capacity of the villi to process absorption, they are present, we call microvillus, the microvilli there. Okay. So this is the microvilli. So meaning that not only they have villus projection, but they have also microvilli. By doing so, the surface that involved with the process of absorption in the site is multiplying and increasing. There's something that very important. But the consequences is that not only if there's damage of the epithelial lining or the enterocyte, a simple cuboidal or columnar epithelial lining, but if there is also damage of the microvilli, that will also interfere with the normal function of the intestine. Probably those damages in microvilli, if the agent only cause damages in microvilli, with less damages in the enterocyte, that condition in terms of clinical sign might not be obviously observed, but yet the animal is not performing well. You can see that the basement membrane there, and this is a blood vessel, very close. Because anything being absorbed from the lumen to the enterocyte, then they will travel into a blood vessel through the circulation. And of course, in this case, you can see in terms of different type of sectioning, not as nice as before, but you still see there's a villus projection, and you also keep a lubricum. Again, they quite multiple layer of enterocyte, not as nice as we observed before, and yet you can see also of what I call it a crypt lubricum. So let me move to the first topics on congenital anomalies. I mentioned this congenital anomalies is important, particularly in newborn animals, because if there's no intervention at early stage of life, animal might die. So one is congenital anomalies, which is more common due to impairment of blood supply to the organ during early fetal life, resulting ischemic necrosis. So when there's ischemic necrosis, there might be stenosis, whether complete or incomplete. And normally stenosis is incomplete. When they're complete, they might have atresia with a complete ulcation of lumen. And this in case might occur in jejunum, in ileum, and also maybe in what I call it a colon. So that can occur leading to atresia, means complete occlusion of the lumen. So if this noticed during the newborn animals, of course the animals is not defecating. So when animals not defecating, one of the possible differential diagnosis, they got a segmental anomalies or they have atresia. Yeah, and what you need to do, of course, surgical intervention by do removing of this area and then do anastomosis within the area. So we need a surgical intervention to ensure or to solve this problem of atresia. There also aplasia or hypoplasia. This example of atresia ani. You can see that some area of the colon that is what we call it completely blockage. And as a result of that, of course, the feed material are not able to be defecated, remain accumulated in the proximal area of this obstruction. And in long run, one, we not expect to see animal have defecation, but the accumulation of this feed material in the proximal area of atresia ani might lead to a toxemia, isn't it? And long run, they might got distension, over distension of the colon, then lead to probably perforation or even those of ingesta that present in the oral cavity of the colon may lead to toxemia, and toxemia could lead to, again, congestion of the organ and poor venous return and reduce in cardiac output. Then the obstruction can be as a result of physical or functional. Normally in cases of physical, is mainly leading to narrowing of the lumen or as a result of displacement. Well, when regard of functional, they might involve nervous or vascular disturbances. So there's an example of narrowing of the lumen. I mentioned earlier, intestine is like is a very long like tube, yeah? And we can see that those narrowing of the lumen can result of intraruminal, mean the presence of foreign body in the intestinal lumen. Either it is parasite, congenital, and many other things. They are also as a result intramural, meaning that at the wall of the intestine. And this could be as a result of inflammation, trauma, or neoplasia. Similarly, also as a result of adjacent compression, adhesion, peritonitis, and neoplasia. So these three things, in lumen, in the wall of the intestine, as well as at the adjacent, lead to narrowing of the lumen. In terms of displacement, usually they have torsion. I think very clear they got torsion. They got valvulus or intussusception. Similarly also, I think we might experience, I think torsion, we have some example is torsion of the stomachs, but in this case, intestine also is susceptible for torsion. Herniation also is quite important in the intestine. You can see that whether there will be internal, normally internal herniation, there is no hernia sac. Example there, you might have omental or mesenteric hernia, meaning that part of the intestine might push into the, what I call it, mesenteric or the omental that lead to herniation. So you not expect to see, we call it as hernia sac. But quite common also, we have more of external hernia, where you find this hernia sac, there will be a ring content. And this can be seen quite a number of cases, that in cases of ventral, umbilical, scrotal, femoral, and even diaphragmatic hernia. So with regard of diaphragmatic hernia, it can be commonly as a result of sometimes when you are in hospitals, when animal jump or maybe fall from the high level, they might come out with diaphragmatic hernia. What happens is that this is quite common also in cat when they got diaphragmatic hernia. Of course, they will puncture of the diaphragm, and the what I call it, the intestinal tract will be placed into the thoracic cavity, and animal will have difficult breathing. if they will rupture or diaphragm, that might lead to air entering the thoracic cavity, animal have a difficult breathing, and that might lead to death to the animals. And normally, we need a surgical intervention to put animal under GIT, and then you close back of the hernia. Okay. This example of intussusception as a result of displacement. I'm sorry I cannot show you how this interception occur actually, but you can foresee that part of the intestine being moved inside to the intestinal area, and this area will later on undergo what I call it necrosis. This is also interception. See that there's small part of the intestine there. They are inserted inside the under part of the intestine. So this will lead to what I call it again necrosis of the affected area. Similar as this one, you can see very severe congestion there, and at the end they might lead to what we call it a necrosis. Torsion, you have a gastric torsion, but you can see the intestinal torsion. When there's a torsion there, of course the intestine is twisted. Then as a result of that, there will be failure of venous return, and you can foresee that those affected area become severely congested. If not corrected to normal position, this very severely congested area will undergo necrosis. And functional obstruction involved with nervous disturbances. Very good example is paralytic ileus, but also as a result of vascular obstruction, as a result maybe thrombosis. Of course, thrombosis associated first with embolism, then embolism might lead to thrombose, then animal might have condition like embolism, arterial thromboembolism. Then in cases of Pasteurella, Haemophilus, Strongylosis, and quite common also in dogs as a result of short gut. And this dog, as a result of short gut, they are so susceptible to perfusion, particularly when you conduct surgery, laparotomy. When you examine the GIT, just examine carefully, because there's tendency that excessive manipulation might lead to short gut in the dogs and might lead to death to the animals. This is what we call paralytic ileus. When there is a loss of nervous supply to this area, as a result, they become narrowing, and you can foresee those are the proximal area. The intestine is highly over detention. Yeah. So, what's important of this intestinal obstruction? Okay. So they can lead, of course, to death to the animals. Usually, animal might have dehydration and metabolic disturbances. When those obstructions occur in the upper part of GIT, that will lead to alkalosis. But this partly because animal will lose a lot of acidity or HCl from the organs. When they occur in the lower tract, they will lead to acidosis, partly because accumulation of excessive acid in the GIT. That's why they have acidosis. Obstruction also could lead to intestinal paralysis, because when there is obstruction, the intestine tries to work hard, and there will be reverse peristalsis. And this reverse peristalsis might lead to intestinal paralysis. Common one, obstruction could lead to toxemia, partly because of alternation in the permeability of internal mucosa. So toxic material will perfuse into the abdominal cavity. Like in cases of, we see that torsion, intussusception, there is massive congestion and lead to hemorrhage and necrosis of the area. And when this is ischemic, necrosis of mucosa might lead to maybe gangrenous, and of course, leading to perforation. And perforation of the intestine, as those in the stomachs, might lead to peritonitis. So this is a bad thing about intestinal obstruction, and it needs to be corrected. Whether commonly also might involve with what you call it surgical intervention. Any question so far? Any question, my class, my dear? Any question, please? No, okay, thank you. Thank you very much.
So far, okay, Doctor.
Okay. Okay. So now it's more important one. I could say important because again, inflammation is so important. And what is so important of the intestine is the epithelial lining of the intestine. If you remember, later on in the liver, they have hepatocyte. But in the skin, got stratified squamous epithelium. Of course, oral cavity have that also. But intestine, the most important one is they have enterocyte. And one of the important response of the intestine towards injury is inflammation. So inflammation of the intestine, we call it as a enteritis in general. But when we might call also when they occur in cecum also intestine, they call it papillitis, but nothing wrong, you can call enteritis. Colon, they call colitis. Again, nothing wrong, you want to call it enteritis. And the rectum, we call it proctitis. And nothing wrong if you call it also enteritis, because enteritis is more of a general inflammation or known definition of inflammatory response to the intestine. And inflammation could lead to infectious and non-infectious. Usually, the non-infectious one will follow up by secondary infection, that lead to inflammation. And if you remember, in the lesion associated with the oral cavity, there are 5 types. You got catarrhal, yes. In the intestine, we have catarrhal. We got hemorrhagic, yes. In the oral cavity, we have vesical, erosion, and ulceration. But in this case, hemorrhagic, because in the oral cavity, perhaps the ulceration will lead to hemorrhage. It's not as severe as those of the intestine. That's why in type of enteritis, we have hemorrhagic enteritis. Fibrinous. Fibrinous is something to do like vesical or maybe ulceration. But in this case, fibrinous is something to do with as the intestine in not completely damaged, but the fibrin from the blood vessel have oozed out from the intestinal tract. That's why the formation of fibrinous enteritis. Necrotizing, because it involved with severe necrosis. Okay, we don't really describe in the oral cavity. And finally, we have glomerulus enteritis. Because necrotizing, maybe you can see in the oral cavity involved with what you call it proliferative stomatitis. So the type of enteritis, they have 5 types, and lesion associated with stomatitis, they have 5 also, isn't it? They have 2 similarity there, mainly on catarrhal and glomerulus. But other 3 is very specific in the intestine, with is hemorrhagic enteritis, fibrinous enteritis, and necrotizing enteritis. Also, I mentioned earlier, hemorrhagic can be as an ulcer, but because of severity occur in the intestine, we call it as hemorrhagic enteritis. Okay. So regarding the agent, this is very important. That's something you need to remember. The infectious one, particularly very common in the intestine. When you look at the lesion, more importantly is bacteria. For example, there we have E. coli, Salmonella, and Clostridium. This is the most common bacteria that can cause enteritis. Viruses, of course, a very important one is parvovirus. Parvovirus very important. Although coronavirus, rotavirus, adenovirus, and pestivirus also could lead to enteritis. Parasite, for sure, you can see Emeria is a coccidia. It's very important. Azospora, and Salostoma, and Ascaris. And with regard of those non-infectious, they might be associated with copper and iron deficiency, dietary overfeeding, and indigestion. But of course, with these changes that lead to what we call it secondary urinary bacterial infection. They might have also portal hypertension in cases of severe congestion as a result of what we call it chronic heart failure. Yeah, right-sided chronic heart failure. That might be portal hypertension. So when you talk about agent, something that you have to remember, because we're going to study those agents when we come to your medicine topics. But of course, you touch also during your microbiology. But in this case, we go more specific how this agent could lead to enteritis, depending on the, of course, sometimes species, but the type of those infectious agent, bacteria, virus, and parasite are so important. The names, something that you have to remember. So, type enteritis, catral, I mentioned earlier, is about the same of those catral stomatitis. Normally, they are acute, hyperemic, hypotonic, flaccid, dilated, and more opaque, and the lumen is accumulated with serous or watery transudate of secretion. Laminar fluid exudation, fluid acrosite, the submucosa thickened. In chronic, maybe they got exudate, tinnitus mucosa, mucous membrane thickened, leukocyte infiltration, and regeneration hyperplasia. But the only difference is that with stomatitis, maybe in terms of gastroenteritis in the intestine, they have a specific agent. Specific agent because in the catral stomatitis, the agent is very non-specific. For example, in this case, for gastroenteritis, as a result of coccidiosis, Emeria acivilana, an example of gastroenteritis. And you look carefully for this photo, you can foresee that there will be white streak. White streak in the mucosa of the duodenum. That white streak. And this is the typical, or we call it pathognomic lesion for Emeria acivilana infestation. So meaning that when you open this, you find those white streak, like in this slide. So this animal actually down with the Emeria acivilana infestation. So they are pathognomics. But the only thing is that this Emeria species only cause catral enteritis, partly because the organism is only occur within the epithelial lining of the enterocyte. They didn't go further beyond that. That's why they can cause catral enteritis. That's why when you go further, this again, Emeria acivilana, you can see there's an enterocyte. And you can see that those are different stages of Emeria acivilana present in the cytoplasm of the enterocyte. They go to the lamina propria and go anywhere. They're only present there. That's why the body response only produce mucus by the goblet cell leading to catral enteritis. No hemorrhage and nothing. If this is only pure case of acivilana infestation. So very good example. But I mentioned earlier, catral enteritis or catral stomatitis but now have very clear specific agent as we observe in cases of catral enteritis. They also can lead to catral enteritis, the ascaris. So in this case, they are more, again, they don't cause much problem because what the ascaris do is it's only leading to irritation of the epithelial lining or mucosa of the intestine. As a result of that, the intestine produces a lot of mucus because the parasite did not really enter into the, what I call it, epithelial lining of the intestine. What this ascaris cause a problem is that when there's so many adult worms in the lumen of intestine, that lead to obstruction of the intestinal lumen. In fact, I experienced during my practice, a patient bring a puppy with very distended abdomen. Then an animal shows some what I call it, abnormalities. And then after that, when you examine, okay, you can do a fecal smear there and so on and so forth. Then when you treat the animals with antihelminthics, the animal will completely recover. Yeah, so the owner is so happy because of your right treatment and right diagnosis, because this can cause obstruction of GIT. Remember, if there is severe obstruction, I mentioned earlier, blockage of GIT could lead to death to the animal if you don't put a proper intervention. Ascaris might not cause a lot of damage into intestinal mucosa. The intestine respond by gastroenteritis, but the complication will be this worm, LDAT worm, might cause obstruction, where the partial or complete obstruction of the GIT might lead to death to the animals. So the second one, hemorrhagic enteritis. Okay, hemorrhagic enteritis. I mentioned earlier in the oral cavity, they might have also hemorrhage as a result of ulcer, but we call it ulcerative stomatitis. In cases of hemorrhagic enteritis, they develop followed by acute or severe damage of the superficial blood vessel. And they are quite common lesion in number of septicemic diseases. In cases, salmonellosis may lead to hemorrhage. Clostridium infection lead to hemorrhage. Parvovirus lead to hemorrhage. Coccidia, of course, coccidia in this case is different species of Emeria. I mentioned there Esevilena only cause gastroenteritis, but you have tenella, Emeria tenella that occur in the cecum might lead to what I call it hemorrhagic enteritis. So when animals have hemorrhagic enteritis, for example, infected with parvovirus, or even salmonella, or even coccidia, what you see is that when you open the intestine, you'll see that the ingesta is stained with blood. And the ingesta is stained with blood. At the same time, intramural thickening and edematous. And when you do histology, perhaps you might see the villus will undergo atrophy, lateral and superficial capillary be necrotized. That might observe under histological lesion. This example of hemorrhagic enteritis. And this, in this case, is caused by melanocatal fever, a disease called melanocatal fever. And this melanocatal fever is due to herpes virus infection. And this is a deer animals. Deer is highly susceptible to melanocatal fever. And what happened is that this herd of deers, which is about 20, I guess, and we keep close to the sheep, close to the sheep. Because please remember, try to avoid, keep deers and the sheep in a close place. They cannot sit very close because sheep are quite resistant to melanocatal fever, while deer are highly susceptible. There's tendency that the sheep might be infected, and then there will transmission of those virus into the deer, leading to death. This is what happening for this deer. We have experiment about 20 deer. We keep this deer next to the what I call it house to the sheep, and as a result, all those 20 deer die of melanocatal fever. And of course, this slide we use for teaching. You can see those of the blood, isn't it? Or maybe in the perineal area as a result of very severe hemorrhagic enteritis. When you open further, you can see those. See how bad is the intestine. Yeah, you can see that. Actually, the herpes virus, apart from damage, they cause a vasculitis, meaning that the damage or inflammation of blood vessel. You can see those are very soft content of the intestinal lumen, and you open, just blood ooze out. Very severe hemorrhagic enteritis resulting from melanocatal fever in a deer. And then in other area, probably you can see even the mesenteric lymph node also severely hemorrhages. Okay. Another important one is a parvovirus. Like in cases of leukopenia or parvovirus in the dogs. Again, there's a case of a leukopenia. Our previous case also, you can foresee those animal down with leukopenia. You can see at the middle part of the intestine, the reddening, some area darkening, and this is what we call it hemorrhagic enteritis. Although sometimes be careful, sometimes torsion also might produce this type of appearance if the intestine is twisted at this area and within this area. But in this case, actually, is hemorrhagic enteritis due to the feline leukopenia. And this is when you look at the lower tract, the colon there, again, in cases of feline leukopenia. So how severe is the hemorrhages? We'll see that later on that this feline leukopenia, as well as what I call it, parvovirus infection, the virus caused damages at the crypt of lubricum. Yeah, we later also cause damages of blood vessel, particularly involved with secondary infection, leading to this very severe hemorrhage. Of course, this type of hemorrhage could lead to hypovolemic shock, again, reduction in a venous return, and leading to reduction of cardiac output, low cardiac output, and death to the animals. So very severe hemorrhagic enteritis. Any question, my class? Any questions so far? Hello?
No, Prof.
No,
So far,
Prof.
none.
No, yeah, okay.
None
Okay,
question.
thank you. I continue. So hemorrhagic enteritis, I mean, the mechanism is slightly different from the ulcer, isn't it? But it can lead to those very severe hemorrhagic enteritis. Okay, this is an example of hemorrhagic enteritis, but this one in chicken, in case of Newcastle disease. And you can see those hemorrhages also of the lymphoid aggregate, lymphoid tissue, in case of Newcastle disease. Of course, even influenza also can cause hemorrhagic enteritis. And then we have hemorrhagic enteritis. In this case, it's coccidia at the middle part of the intestine. They're caused by Emeria necratrix. You can see those at the serosal surface, pinpoint hemorrhages. But when you open the lumen, they have very severe, what we call it, hemorrhagic enteritis. Then we have Clostridium infection. You can see those also very severe. This is actually is a lymphoid aggregation or pear patches. You can see very severe, again, hemorrhagic enteritis. And then we have what we call it fibrinous enteritis, which is not seen, we not really discuss so much on the stomatitis, but this one they got fibrinous enteritis. But the involvement also involved with the blood vessel. I mean, in cases of hemorrhagic enteritis, when you say hemorrhage, there's a rupture of blood vessel. Hemorrhage must be a ruptured or blood vessel. So the hemorrhage there. But in this case, because the fibrinous enteritis developed following an acute but less damage of the vascular system, that lead to increased permeability of fibrin effusion, meaning that when the blood vessel becomes so distended without much damage, so fibrin, which normally would not escape from the blood vessel, now is escape, and they will effusion from the blood into the lumen. That will lead to the so-called fibrinous enteritis. Of course, this fibrinous enteritis later on will lead to also hemorrhagic enteritis. But at this stage, that's how they develop of fibrinous enteritis. The lesion normally hyperemic, edema, and for sure, there will be exudation of fibrin, mucus, and leukocyte. I think the fibrin is so important, where this fibrin will produce pseudomembrane form if the fibrinous exudation accompanied by superficial necrosis. And they might have also local erosion and ulceration. Okay, but yet we call it as a fibrinous enteritis. Example there, we got Salmonella again, Campylobacter, and swine dysentery. And this is example of we got the combination of we got fibrinous, ulcerative, hemorrhagic enteritis. I don't have photo for just fibrinous, yeah. And this very good example in cases of hot cholera or swine fever. Again, all those slides I showed to you is the cases that we have at UPM. It is not from the internet, it's our own case that we have. So we have swine fever or hot cholera. And usually in cases of swine fever or hot cholera, salmonella also been isolated. They might come together. We are not sure why. Some people thought this ulceration is as a result of salmonella infection. Some say due to the hot cholera. But most of the time, when you see this type of ulceration, both swine fever or hot cholera as well as hot cholera viruses, as well as salmonella being isolated. They come together. So this you can see, in terms of surface, again, fibrinous, ulcerative hemorrhagic enteritis. We call it actually, this one is a button ulcer. Yeah, it's like a button later on when you open under serosa, mucosa. This under serosa surface, you see those of the rounded, isn't it? Area of ulceration. From this ulcer, they produce fibrin, at the same time, hemorrhage. And this is what we call as a button ulcer. Okay, rounded there. And very typical, even pathologic lesion for hot cholera or swine fever. Okay, and also we call it salmonellosis. Then the third one, necrotizing enteritis. Mainly there are coagulation or caseous necrosis or the facial layer of mucosa with minimal inflammatory responses and early stage. So we have Clostridium perfringens, bovine variolaria, again salmonellosis still there, and Campylobacter infection. But more importantly, in this case, necrotizing enteritis in cases of tuberculosis. So this is our case of tuberculosis. We involve the intestine, very severe lesion in the intestine, very severe lesion in the lungs and other organs. This case is again tuberculosis in deer. I think at one time the government have a policy to they import a deers overseas, and fortunately one of these deers from the imported deers down with tuberculosis. And I did the necropsy and postmortem, and you could see there how significant or how severe a lesion that occur in the intestine. You can see the area of hemorrhage. You can see area of necrosis. Yeah, and we have there, of course, is what I call it, twisted or folding of the intestinal mucosa. So this is a necrotizing enteritis. In tuberculosis, you can differentiate later on the lesion of Mycobacterium paratuberculosis or jaundice disease, which is different, because they don't have those of necrotizing enteritis. Okay, very severe and very good lesion to understand and to describe. At the same time also, in case of tuberculosis, you can see the abscesses in the mesenteric lymph nodes, okay? And there might be also necrotic enteritis, the involvement in the cecal tonsil. In this case is colligranuloma. It is E. coli that occur in the cecal tonsil or cecum of the bird or chicken. Our case also. So finally, we have granulomatous enteritis. So we have also previously granulomatous stomatitis, isn't it? In this case, granulomatous enteritis. Of course, when you talk about granulomatous, it is chronic inflammation. When you talk about chronic inflammation, normally you expect more of a giant cell maybe there, or maybe macrophage. And very good example of granulomatous enteritis is jaundice disease caused by Mycobacterium paratuberculosis. You can see the difference between necrotizing enteritis and granulomatous enteritis. This is a cow. GC, I guess, is jaundice disease. Cow from our farm. Usually we have farm from TPU. So this is a milking cow. And we have Gromentous enteritis. The animal actually is emaciated. And one of the very typical clinical signs reported actually is that from history, animal have shooting diarrhea. When you shooting diarrhea, animal have frequent diarrhea, then the content of the diarrhea actually mainly is more watery. Yeah, meaning that animal have failed to reabsorb back the water in the GIT. So they have shooting diarrhea. Animal have good appetite, but keep on emaciated. So this is an example. And when you open, look at the intestine. This is how the intestine look like. When you compare with those of the tuberculosis in deer, yeah, you don't see area much a lot of necrosis, hemorrhage, and necrotizing tissue. What you see here, only thickening of the wall of the intestine, yeah, wall intestine thickened because they're opaque there, and they are folding, transversely folded of the intestinal mucosa. They're folding there, okay? So they are folding. You can see why they are folding, actually because there is very severe infiltration of inflammatory cell at the submucosa of the intestine that lead to folding of this intestinal lumen or intestinal mucosa. So that folding, of course, will lead to shortening of the villi, will lead to also what I call it inefficient process of digestion and absorption. That's why animal having a shooting diarrhea. So this is how the folding look like. Look very fresh, although some area of congestion. But otherwise, you can see a lot of mucus, still a lot of mucus there. There's some area of congestion there, not hemorrhage. But otherwise, they are quite clear when you compare in the case of necrotizing enteritis, isn't it? Okay, in cases of tuberculosis. But this is Mycobacterium paratuberculosis. And this is how we can see, this is not from me, this is we got from somewhere else. You can see those of the transverse folding of the intestinal tracts. Okay. And when you do, in fact, we have this slide for our histological examination during practical class. So you can see those of the muscular layer, the longitudinal and transverse muscular layer, the basement membrane there, then you got mucosa here. So in mucosa of the intestine, when you look carefully there, of course, you don't see a lot of villus projection. Yeah, there's no clear villus projection here. And you can see those of the darkened area, dark. Actually, this area comprised of infiltration of mononuclear cell. So in the basement membrane here, in this section, you can see quite clear. And when you look carefully in other slide, actually, you can expect to see in this of the submucosa, they will be also heavily infiltrated by inflammatory cell. We have the slide for the practicals. Then what you observe, apart from those of the chronic inflammatory cell infiltration, comprised of macrophage, you see also this what we call as a giant cell. Very nice ring-like giant cell there. So this giant cell actually a accumulation of macrophage in fighting against the bacteria. So they come together and then to eliminate the bacteria. So again, this is quite typical lesion for jaundice disease. Okay. Any question, please? Class, any question? Are you still with me?
Yes, Prof. No questions.
No question.
Okay, I try to please. But we're going to see again the slide during practicals on Wednesday. Yeah? Okay. Then less important, inflammation of the colon, we call it colitis. May result from entry of bacteria and uptake of toxin, in toxemia and septicemia. An example of colitis can lead as a result of Trichoris vulpis infestation. Again, flank fan leukopenia is important. swine dysentery, bovine viral diarrhea, and jaundice disease. About the same over the middle part intestine. Then we have hemorrhagic and necrotizing typhlitis. You can see how severe is the cecum as a result of Emeria tenella infestation. Very severe hemorrhage. Because in cases of Emeria, in case of Esavelena, the coccidia is only infiltrating the enterocyte. But in cases of Emeria tenella, the coccidia actually, the protozoa actually, they are infection cause infiltrating in the mucosa, submucosa, and involving also the blood vessel. That's why you can see those of the hemorrhages. Very deep infiltration. And this is a case of hemorrhagic colitis. In cases of trichuris infestation, again, there was slide there, you can see those of the LDAP worm there. And you do histology, you can see the presence of those of the LDAP worm. So usually in this case, sometimes in cases of trichuris infestation, there are more accidental findings. Accidental finding means that animal might die or do something else. When you conduct necropsy, postmortem, you observe the presence of the parasite in the column. Okay, we have about 20 minutes. This topic also very important. We have only one slide, but there's so many things we can ask from this one slide. Okay, so we call it as villus atrophy. So villus atrophy is a very common term being used by many people. Any problem of absorption, they may say villus atrophy. So the question is that what can cause villus atrophy? You remember the epithelial lining of villi, we have villus projection. Then at the same time, we have a crypt or libicum. I mentioned earlier, what I call it, the villi or the crypt or libicum is a factory. Yeah? It's where the cell actually undergo mitosis. And this epithelial cell forming a simple cuboidal or columnar epithelium, moving from the crypt or libicum and move up into the villi. Then within 3 to 5 days, there will be necrosis by apoptosis and extruded from the epithelial lining. So there is normal mechanism of epithelial lining replacement in the intestinal tract or in the villi. They all keep on replacing. So villus atrophy can cause by two main factors. One, when there's damage on the crypts. When damage on the crypt, of course, there will be reduction of matured cell, because in crypt is immature cell. When the damage there, the production of mature cell will be reduced. Villus atrophy also can be a result of the loss of the cell in the villi. Meaning that when the infection causes only damage to the villi. So when you look carefully there, of course, when the cell causes damage to the villi, the tendency that that cell will be replaced from the immature cell that is produced in the crypts. Okay, meaning that they can be replaced until the rate of destruction is much faster than the rate of replacement. That leads to atrophy. But what happens is that when there's damage of the crypts, when the damage of the crypt, there will be less production of mature cell. Meaning that when the crypt is damaged, there's a tendency that failure of mature cell in the villi. So that will lead to again a villus atrophy, and perhaps this type of villus atrophy that cause damage of the crypt may cause more significant impact when compare damage of the villi. Okay, quite clear. So more importantly for you to remember is that what agent can cause damage to the crypts and what agent their target site is only of the villi. So I give you an example there. Parvovirus, I think parvovirus, hemorrhagic enteritis, plant leukemia, hemorrhagic enteritis, that actually the damage is occur at the crypts, as well as bovine viral diarrhea. But Other viruses, for example, in cases of coronavirus, rotavirus, coccidia, depending on the type of coccidia, maybe Elimina sevillana, they cause only damage of the villi. So that is an example of agent that lead to what we call it villus atrophy. Yeah. So to remember the agent is important because from there you can understand in terms of what is the mechanism of villus atrophy, and the consequences of villus atrophy could be so many things. One of the consequences, of course, animal will have diarrhea. Okay. Any question, class? We will going to have a practical also, and we're going to discuss this on the villus atrophy. Yeah. This is a creep the villus atrophy I mentioned to earlier. We have creep albicum down here, and we have villus projection there. And the creep albicum will produce a more mature cell. They have a lot of mitotic cell, and when the cell get matured, they move outward and replacing the epithelial lining of the villi, and then they will be extruded from the tip there within 3 to 5 days of the production. So the epithelial lining keep on replacing. But unfortunately, for example, like parvovirus just now, they can cause damage of the creep albicum as a result of those damages. So the replacement of cell in mature cell is much slower and leading to shortening of the villi. But in cases of, for example, coronavirus, because damages of the epithelial lining, and if the rate of damages is much faster than the placement of the cell from the creep, that will also lead to villus atrophy. And villus atrophy can lead to many consequences. Okay, the last one, we have diarrhea. Diarrhea also very important because the one of the important clinical sign in GIT. And diarrhea can be defined as passages of feces with excess water and fluid. Usually they are very soft, more water, and more importantly, they have greater infrequency than normal. So the frequency is much more normal than usual. I think many of us experience of diarrhea. And with regard to mechanism of diarrhea, there are 4 mechanisms there. Common one is osmotic diarrhea. Then they might have also secretory diarrhea, exudative diarrhea, and disorder of mortality. So we have 4 mechanisms of diarrhea in terms of classification. But in cases of diarrhea in animals, maybe more than one mechanism might involve. Yeah? When animal have diarrhea, usually there are more than one mechanism involved. Why we classify this? Partly because for easy for us to understand the mechanism. But in real sense, the incident or the mechanism or the type of diarrhea might involve more than one. In the animal, we have diarrhea. Same thing also in terms of enteritis. Although we classify the lesion into 5, but yet in condition of enteritis in animals, many times also they have more than one, what we call it, type of enteritis. Okay. So one is osmotic diarrhea. Will occur when water-soluble molecules are fully absorbed. Okay, meaning that water-soluble molecules are fully absorbed, and this many occur as a result of maldigestion or malabsorption, or even in villus atrophy. Because in villus atrophy, the efficacy, the efficiency of absorption is poor. Then as a result of that, they will retain of this water-soluble molecule in the intestinal lumen. When they maintain, they will attract, okay? Apart from, they will attract the fluid from the body in the intestinal tract to ooze out into the what you call it, intestinal lumen, because the osmotic pressure in the intestinal lumen is higher. So they will take or pull the fluid from the intestinal tract into the mucosa or into the lumen of the intestinal tract. At the same time also during that period, there are poor reabsorption of the fluid. So as a result of that, the excessive fluid in the intestinal lumen leading to diarrhea. Other can lead also like result in cases pancreatic insufficiency, acute and chronic enteritis, and lactase deficiency. Lactase deficiency is something to do with taking of a fresh milk. And we have secretory diarrhea. And this secretory diarrhea mainly occur when the mucosa of the large or small intestine, they secrete rather than absorb. And that result of endotoxin. For example, like Vibrio cholera, E. coli, Salmonella. They secrete, they stimulate the intestine to secrete rather than to absorb. That's why we call it as a secretory diarrhea. Example is important because I mentioned earlier, only this type of organism, for example, there are bacteria, could produce endotoxin and leading to secretory diarrhea. Exudative diarrhea, they occur as consequence of outpouring of serum protein, in case of salmonellosis, blood and mucus from the site of ulceration, inflammation and irritation of intestinal lumen. Inflammatory bowel disease, hookworm infestation, that usually associated with exudative diarrhea. Disorder or mortality, meaning that the intestine become increased in terms of the contraction, hypermotility. Usually is due to disturbances in normal intestinal nervous activity. More common one maybe is allergics or anaphylactic reaction, but people reported also can be a result of copper deficiency. So the mechanism that I mentioned earlier, although we have 4 classification diarrhea, diarrhea usually can be mixed, involving more than one mechanism. For example, in cases diarrhea due to parasitic infestation, what might involve probably secretory diarrhea, osmotic diarrhea, and even exudative diarrhea. So they are of a combination or mixed than one. So we classify into 4 partly just easily to understand the mechanism. Oh. It seems that we end there. Any question, class? You have a long day, almost 2 hours. Do you have any question?
I'm just thinking, like, how do you differentiate the type of diarrhea? Because they all look the same. Do you have to look at the
different. Of course, it's different. You mentioned earlier when you have osmotic, mainly because there are increase of osmotic pressure in intestinal lumen. The mechanism. Of course, when you see the diarrhea there, they are about the same. But of course, osmotic diarrhea usually might involve the common one, like in cases of Mycobacterium paratuberculosis, jaundice disease. They're almost purely osmotic diarrhea. Okay. Then you can see there's a shooting diarrhea. Then you see there's a fluid, and the fluid look normal. So very typical in cases of osmotic diarrhea, like in cases of what we call it jaundice disease, because there are more those lot of venous atrophy leading to maldigestion, malabsorption. But in cases of secretory diarrhea, you can see a lot of mucus, mucus rather than a pure fluid. And in this case, they are usually involved with toxin. The feces comprise more of mucus, just not pure fluid, isn't it? But of course, if we talk about exudative, in this case, be careful. The feces also might contain a blood. Is that outpouring of protein might be blood also, because the area of ulceration and so on and so forth. So you can see the blood in the feces. There's possibility they might have exudative diarrhea. And then disorder mortality, again, disorder, normally, well, the fluid is contained, whether it is a more complete water or maybe just at the ingesta, because this is a matter of increase in contraction of the intestine. And this type of diarrhea also, you can determine tentatively by using your stethoscope and look at the sound as long as movement of the GIT. So your stethoscope is very important. Yeah, although we have new technology now with many other what you call CT scan, MRI, and so on and so forth. But your stethoscope, so important indication in coming up with your tentative diagnosis. By looking at the sound of the GIT, you might say that, is it increase in the contraction? Is it normal contraction? Is it less contraction? Then you might able to see, is the content there is a fluid? Is the content there is more mucus or other thing else? So you can see in terms of those definition itself, you might able to differentiate this four type of diarrhea. But yet I mentioned to earlier, in the case of diarrhea, animal might have all those type of, animal have more than one type of this diarrhea. Is it okay with you?
Yeah, okay, Prof. So if we want to write a report, do we have to describe the diarrhea like it's osmotic apa ke?
Later on when you come, maybe later on when you come to our case study, we have question there. See how? Yeah, you understand that? Oh, you mean when you are report in your clinical, is it?
Yeah.
No, normally clinical you might if you're able to do identify do the examination, you can put the tentative because in terms of the treatment also they are different, you know. If you have a disorder mortality, for example, hypermortality, so what you need to do if there increase in mortality, a contraction, yeah. That's why normal we also when you go to clinic they give you low motil, where they want to reduce the contraction. Okay, as a result of that, by give that treatment, so the contraction less, then the diarrhea is stopped. But if the diarrhea is a result, for example, as a result of exudative, you give that, so it won't harm, it won't help, even it cause harm. You know why? Because the contraction in intestine is slow, then all the toxic material accumulated in GIT. You get what I mean? And as a result of that, they are of course more toxic to the animal rather than you give a therapy. So in principle, it's important for you to classify the type of diarrhea. But if you're not able, probably you might able to do for other means, not only by doing auscultation and so on and so forth. That's why when animal have diarrhea, one of the important lesion also you're going to ask how frequent is it? Then what type of the feces? You examine the feces, what type of feces? I mentioned here if the feces got blood, you might suspect it's a exudative diarrhea. If it's got a lot of mucus, this might be mucus diarrhea. If it's only frank water, so it might be just osmotic diarrhea. But when you have mixed, maybe frank water and some feces, and there might be increase in a contraction of the intestine. Okay. And this is in terms of practice, because pathology will come to practice actually, because all of you will be veterinarian. So that's important concept there. So meaning that by now, when you have diarrhea also, you start to consider what is type of diarrhea that you have. Okay. It's a result of what you call it. Maybe you got osmotic diarrhea, just normal one, after taking milk. Yeah? There could be like taste deficiency, osmotic diarrhea. It's normal type of feces. Yeah. But you can start to get blood there. Be careful. Okay. So by doing so, I think we can start to practice understanding those type of diarrhea. Any other question? We have a few more minutes, 2 or 3 minutes.
Hi, Prof.
Yes.
I have a question about fibrinous enteritis.
Yes.
Like one of the definitions stated is that a pseudomembrane is formed if the fibrinous exudation accompanied by superficial necrosis. Yeah, I don't understand what does that mean.
Okay. What you call it is that in cases of fibrinous enteritis, please remember the main concept is that the fibrin actually is from the blood vessel. So in this case, the blood vessel is less damaged and they become something like dilated. As a result of that, fibrin will escape from the blood vessel. Okay. But unfortunately, I mentioned earlier, there is a very typical case of fibrinous enteritis, meaning that the only presence of fibrin covering the epithelial mucosa or the intestine. But in many times, there will be also necrosis of the cell, unfortunately. Okay, so in that case, that's why, although we didn't cause here a necrotizing enteritis, but in many times we got fibrinous enteritis, you might have also superficial necrosis of the cell. So when there's a cell necrosis, when there's fibrin formation, so this necrotic cell and fibrin will come together, and that will form a pseudomembrane, like a membrane covering the mucosa or the intestine. I think I have that photo a long time ago, but I couldn't find that photo to show those of pseudomembrane. Okay, meaning that you have a fibrin from blood vessel as a result of damage or changes in the blood vessel capillary. That at the same time, there is a superficial cell necrosis. That's why you see pseudomembrane. Okay, does that answer you?
Yeah, thank you, Prof.
Welcome. One last question maybe before you go for lunch, or you have another class after this? Do you have class after this?
Yes, Prof.
Oh, you have the class and you have to stop here. I'll see you again on Wednesday at 12 o'clock. Okay, thank you very much. And see you on Wednesday. And I leave you for your next class. Thank you.
Thank you, Prof. Nice day.
Thank you, Prof.
Okay, bye.
Thank you so much,
Welcome.
Prof.